Hello, everybody. Good Friday afternoon from my place, but I don't know what time is in yours. Welcome in our third webinar. It's annual event we hold on Hats for Children's Palliative Care. Welcome. I hope you will enjoy today webinar. The theme is very broad. It's the speakers will talk about transition from different part of children's life. And I would not hold you on from the talks, and I will give a word to Julia Downing, the president of ICPCN. Julia, please.
Thank you very much. And it's good to see everybody here. And so I'm just going to give a brief reminder as to why we've all got our hats on today. And I had people from all over the world who are wearing their hats today for children's palliative care. So why do we do that? Well, we want to make sure that children's palliative care is available around the world to every child with a life-limiting and life-threatening condition. And so this is our annual day of advocacy, our annual day of recognizing the many different roles that people play within children's palliative care, recognizing that there are countries where there still is no access to children's palliative care. So we wear a hat. This is our friend Charlie, who's got 21 hats on his head today. And that's because there's over 21 million children globally that need access to palliative care. But also we wear our hats because we know that parents wear many different hats as they're caring for their children, as do us as health professionals. So it's about raising awareness. There's over 21 million children around the world who need palliative care, but we know that only around 5 to 10% can access palliative care. And it's 10 years since the World Health Assembly resolution on palliative care. And yet still, there are many places where there is no palliative care services. So it's about closing the gap, helping us to close the gap for access to children's palliative care. And you can see here, this was in 2013, just a rough idea of where children's palliative care is available. The darker the green, the more integrated. This was 2018 and 2023. We're getting there, but we still have a long way to go. We still have many countries where access to palliative care is in the red color here. And this shows the developments. We're moving, and it's great to see that movement, but we still have a long way to go. We know that 48% of countries still are at the lowest level of children's palliative care development. 57% of countries don't have access to the essential medicines needed for children. 50% of services rely on grants and philanthropy. They're not funded by the government. This just highlights the need for access to medicines. This was back in 2017. And you can see that whilst some of Western Europe is there, other parts of Europe are missing, Africa's missing, Latin America, Asia, because they don't have access to the medicines that are needed. This is specifically thinking about morphine equivalents. We need to close that gap. 38% of countries, there's no known research in children's palliative care, and that's 38% of the countries who have access. So that's not including those that we know don't have any children's palliative care. Only 32% of countries have training for doctors and 26% for nurses on children's palliative care. And only 11% of countries have a policy for children's palliative care. So we have a long way to go to close that gap. So today we have our hats on to think about all the different hats worn by parents, carers, and health professionals, but also to raise awareness for children's palliative care. So thank you for joining us, and please do put on your hat, take a photo, put it up on social media, #HatsOn for children's palliative care. Thank you. So I shall stop sharing. And I was about to introduce our first speaker, but I can't see her. I don't think Alex is yet with us. So we might have to go in a different order. Is Carsten, are you there? Would you be able to start?
He's
Not
joining in 10 minutes only.
Okay, so let me okay, so whilst we wait for Alex, Maggie, would you like to just tell us a bit about the Children and Young Persons Task Force or reference group?
Yeah, reference group. Yes, I will. Thank you. Now we were a task force for a long time, but since a couple of years we are a reference group for children and young people from EAPC, and we are aiming at building a national European network for about children's palliative care. We do a lot of networking work. We are busy with research projects. We are stimulating research projects. Oh, I see Alex is there. So
Hi,
if you are interested, let me finish this little part, Julia. If you are interested in joining us in our reference group, please find the EAPC website, our own page on this, and join us. Thanks.
Yeah, muted.
Thank you very much, Maggie, and it's great to see many people joining us. And if you're listening on catch up, do please join the reference group. So we are going to be looking at different transitions around children's palliative care, and in particular we're going to be looking at transitions within perinatal care and then transitions between children's services and adult services. So we're really delighted to have Alex, and she's just popped in from another training that she was doing. So thank you very much, Alex, for fitting us in and finding the time. So Alex is the National Lead Nurse for Neonatal Palliative Care, and she runs the National Neonatal Palliative Care Programme in the UK, and I'm sure she'll tell us a bit more about that. So Alex, over to you.
Hi, Julia. Thank you so much for the introduction, and I'm delighted to be part of today's session. And again, thank you very much for inviting me. Just double checking, am I going first? Am I sharing my slides now, or do you have my slides to share? Okay.
Would you like to share your own, or I can share them?
Yeah, no, that's fine. I can do my own. Okay, great. Just give me a second and I will be right with you.
It's great to see, looking down the list there, great to see people from so many different countries joining us as Alex is getting her slides. So it's great to see Yulia from Kazakhstan and Kate from Derby and Burton Hospitals in the UK. We've got Carla from Spain. We've got Marisa from Maastricht. Jamie from Malaysian Borneo. Barcelona, Spain, Esther, Claire from the UK, Maria from Denmark, all over the world. The Netherlands, the UK again, Natalie from Belarus, welcome. From Levanto, from Denmark, Czech Republic, Austria, Romania, you're welcome. Alex, over to you.
Thanks ever so much, Julia. And yes, I'm delighted to be here today. I am representing the UK as the National Lead Nurse for Neonatal Palliative Care. And for the next 20 minutes or so, I'm just going to give a bit of background on the work that's been happening in the UK and sharing with you a fantastic new document which has been developed by the British Association for Perinatal Medicine that really has become the foundation of all the care that we're providing. And I can see down the list of names that there's a few of my colleagues from the UK, so in the group today. So delighted, as well as people from all over the world. But there are so many elements that are absolutely transferable to different countries. And I think the real summary is that whilst we know that there are specialist palliative care teams that need to be funded, there are nursing roles that need to be funded, there are also many principles which don't need funding, and it's about a philosophy of care and a philosophy of care in the approach to caring for babies and their families at the most difficult times of their lives. Now, on my first screen here, you'll see that along the bottom, it says that I'm supported and endorsed by BAPM, Together for Short Lives. Some of you will be familiar with them, and Bliss and the Neonatal Nurses Association in the work that I've been leading across the country. So today I'm going to give a bit of background, think a little bit about transition and what it means, the principles of perinatal and neonatal palliative care, and then support for healthcare professionals. And really, when Julia asked me to do today's session, it was really thinking about, what does transition mean? Now, I know that in children's palliative care with the older children, it's about the transition, it's the movement from children's services to adult services. But certainly the clear, pure definition is the process of changing from one state or condition to another. I prefer to think about it in this perinatal context. It's about the continuum of care. And the continuum of care right from the moment of fetal medicine support, right through maternity, neonatal, postnatal, and then continuing into children's services and what that might look like. Still a period of complete uncertainty requiring parallel planning. And whilst I'm sure today we will talk a lot about definitions and what the criteria might be, I really like this very straightforward, simple quote from a physician in San Diego, simply saying, my job is to understand what makes a good day for you, your baby, and what we can do to have more good days, and what's really important as we think about the future. These are just some two key documents that have been published in the last year within the UK, but it is focusing on data used around England and Wales, and it just gives us the snapshot view of the number of babies that might require palliative care needs. However, this does not include the antenatal babies, that those statistics are very different, and it's been very challenging to collate that information. So these two papers are very much talking about the time that a baby is admitted to a neonatal unit. And we know when we're talking about the perinatal phase that many babies aren't admitted to the neonatal unit. Babies may be supported at home or within children's hospices, but may never actually be admitted to an acute setting. And as I said previously, that transition, which I do like to think of as continuum of care, where you're moving through different specialties and different periods in that baby's life, it has to be a continuum of care. We have to collaborate with each other, with different specialties, different departments, people in the community, teams in the community, as well as the acute settings. So it's a continuum, an absolute continuum. And I am going to refer to shortly is the BAPM framework, the new British Association for Perinatal Medicine framework that we published in July this year, and I will send you the links to that as well. And you can see that on the left of the page, it's very much thinking about the circle and continuum of care. Previously, many years ago, back in 2010, when we developed the first framework, we thought about the 5 key categories that mirror the Together for Short Lives and the Royal College of Paediatrics and Child Health, the key criteria for trying to look at babies meeting that criteria and being able to access services. Within BAPM, we included a 5th criteria, which was thinking about the unborn baby. With this new document, we're thinking much more about how we have the discussions amongst our team, with parents absolutely central to that discussion and the decision making. And here you can see the 3 circles that are interchangeable when we're thinking about those babies, how we recognize those babies and families who may benefit from palliative care. So the diagnostic approach can be very much simplified within the antenatal period. We may have a diagnosis, we may also not have a diagnosis. So that's when we think about the multidisciplinary concern, when we're talking together as a team about the additional support that this family may require, that there's the uncertainty for this baby's life and what the future might look like, but really bringing various teams together, so having different perspectives. And then, of course, there's the surprise question, which has been used for many years in the children's palliative care world and been adapted from the adult palliative care world, is would you be surprised if this baby died in the short or longer term, prompting further discussions. And back to the circle, and again, the continuum of care, thinking about that absolute holistic family approach, thinking about cultural needs, the spiritual needs, really asking a family what's important for them. How can we support them through this time and ensure that all the principles of palliative care and all the pillars of palliative care are absolutely identified? And the reason this is a circle instead of a flow chart or a tick box or a checklist is because it continues. It goes round and round in that continuum of care. Thinking how we can continue to support parents during that period of time, and flexibility, and what might be important for them today might be different tomorrow. It's having that flexibility, always having a plan, but having that time to spend with families to think about parallel planning, different scenarios that might occur, and how we might approach care, and will that be different? And then that continuing bereavement care after the death of a baby. Although we know that families experience grief and loss when the baby hasn't died, grief and loss for those elements of that baby that they had envisaged for their life and what that might look like. And trying to capture, really bringing everything back to simple terms, as I said, started off with the quote, is what's important to that family, all those opportunities when we can really think about taking those opportunities for a family to be together. And in the UK, we're very much focused on family integrated care and really having that approach to care, which is enabling and nurturing the family experience. Now, the training session I've just been on now, we've been talking a bit about memory making, but certainly we have moved our ways of thinking that every opportunity, every contact that family has with their baby is an opportunity for making memories. So there's tangible and there's non-tangible. And really just when can we get those families to be together? Bring the siblings together, the grandparents together, to really ensure that that family has the best possible time without really knowing how long that baby may survive. And going back to the BAPM framework is looking at those 3 circles that I mentioned previously, and then looking at that circle and how we think about that when we think about planning care. In the UK as well, we have just recently had another very helpful resource published from Bliss and Together for Short Lives. And the QR code is here so you can download that. And it's thinking, this is a parent information booklet that was absolutely co-produced. We're really thinking about how to care for your baby when the future is uncertain. And primarily, again, I'm a huge advocate of this. And next week, I'm not sure if Julia talked about it, there is a very large European Children's Palliative Care Conference, 3-day conference, where really focusing, I'll be speaking about how we need to support healthcare professionals. Because if we don't support the teams who are then supporting families, they just won't have that resilience. They won't have that capacity to continue supporting families in the way they need to be helped. So really thinking about what's important individually, having that self-awareness, thinking about your own well-being, thinking about your colleagues, Many of the healthcare professionals that I speak with also have managerial responsibilities, and that can sometimes be an absolute conflict and a challenge of supporting yourself whilst also supporting your team. There is constant media highlight and spotlight about difficult situations, challenging situations with families, and really thinking about that complex decision making. We know that research has really taken an absolute spotlight, and we're developing that data and the statistics that we need to underpin clinical care. But we also need to be realistic about what's possible where we work. And there's not one professional group that can provide all the care and support a baby and their family need. So really, in summary, is really thinking about, going back to my previous slides, about what's important for a family. How can we support that? What does it look like? Sharing information, we need to have the most up-to-date information so we can share that with families at the most timeliest manner. Offering those choices, having a dedicated key worker who can coordinate this care with all these numerous teams that need to be involved. That multi-agency approach and that collaboration, which is continuous. And that shared learning and training, we have to learn together and we have to train together to ensure that we share our experiences and learn from them. Be curious, explore, collaborate. We can't just, as I said previously, have one professional group that can provide everything that families will need. Having those early, honest conversations. Many people also say that how do they have those conversations? And there are many advanced communication skills training opportunities to be able to circumnavigate that. Thinking about that parallel planning, having that compassionate leadership, personalized care. We know all our families are individual. And whilst I have made a lot of reference to the BAPM framework, it's just a framework. It's never going to be one document that will support everything that a family needs, but it can help you plan the care, really think about what's important for families and ensure that every consideration is given. Thinking about that support for the whole team and what that looks like, that it is continuous and that it is valued. And of course, the workforce development. We need to have dedicated and funded roles to be able to lead this care. And then just to finish really is to signpost you to the e-learning modules that we've developed, which sit on the International Children's Palliative Care Network website. There's the link here, and I will share further links to the introduction to neonatal palliative care. And then there are several sections which are part of the enhanced course. When you go onto this website, there are fantastic resources. There's lots of different titles and in many different languages. So just to leave you with a quote from a parent that I cared for many, many years ago now. And very simply, good training, guidance, and support is essential to empower staff to reassure us as parents that we do not have to worry about the practical aspects of our baby's condition. We can then concentrate on being the best parents we can be for whatever time we have left with our precious children. This mum, Caroline, gave birth to baby Bridget. I met her antenatally. Her baby was diagnosed with thanatophoric dysplasia. That at that time we weren't sure whether Bridget would survive pregnancy or survive delivery, or how long she may live. She survived for 10 minutes after being born. And I spent a long time with mum during the antenatal period in thinking about what was important for her. What did she want to happen? Who did she want to be there? Who needed to support her during her pregnancy? Who needed to be there at the time of delivery? But I think she very succinctly has put this, the importance is that we all work together and continue collaborating. So thank you very much for inviting me today. I'm very happy I think there's a Q&A in a little while, but here are my contact details, and I'm very happy for anybody to contact me outside of the meeting. Thank you.
Thank you very much, Alex, for this wonderful presentation. We have, I see one question in the Q&A, but it's an all-over question. But I think let's do it at the end. But I have a little question, Alex. It's wonderful to see the continuum of care. Do you have ideas how we can organize it in the work field with all the different organizations who have to put a piece of the continuum?
So Maggie, that's a very good question, because that really is a challenge. And that's part of the purpose of my national training program in the UK, where in fact, as a perfect example, and I know there's some people here today who were on the training session before, which is I run virtual training sessions and invite people from all different backgrounds. So people from children's palliative care, the community, fetal medicine, maternity, and we all share, we have a topic and we discuss it and we come together to understand what's happening in the rest of the country, in different regions, and how we can try and incorporate that into our own place of work. So just as an example, what we talked about earlier today was about choices in location of care. So we had a representative from a transport service, the physicality of transferring a baby from one hospital to another or to home. We also had children's hospices speak about the services and support they can provide. And people are connecting with each other in neonatal units and fetal medicine and speaking to each other. But we need to have a platform to be able to do that. So you can do that within your own region, within your own acute setting hospital, or you can do that virtually. And I think that certainly is something that has been incredibly helpful post-COVID, post-pandemic, that we are connecting like this. And again, today's session is an absolute example of that too.
Second question, are you experiencing problems with financial problems with the there's no money for parts of the continuum? Political lobby, I think it's a big issue in UK also.
So Maggie, yes, that's always a problem. And that's always an issue. And that's part of my national work as well, where I'm currently working with our government to try and develop dedicated and funded posts for our nursing teams, because there needs to be someone that coordinates all of this care. You can have all of these teams, but to bring them together, you need to have a key person that will coordinate that. And usually that is a nurse, and they are best placed to provide that. So I'm currently working, we do have the same issues in the UK, but we also have some examples of where it works well and where it is already being funded. So yes, there is definitely funding issues, but I also believe, Maggie, that it's about the attitude, it's about the philosophy of care and changing the culture.
Yeah, thank you very much. Oh, it's from my heart. Thank you, Alex. I think we can continue with the program because I see no other questions in the Q&A.
No, and if there are questions, I think at the end you can ask questions to all of the speakers. Then it's now my turn to introduce Karsten van den Wijngaard from Belgium, and he's a policy advisor on healthcare transition at the Ghent University Hospital in Belgium. And he will talk about the transition period from pediatrics to adult care. Karsten, can you share your screen and slides with us?
Yes, I will. Do you see my slides now?
Yes, but not in full screen. Not, yeah. No. But it's okay, I think. But
can I do it like this? Yeah.
Yes.
Okay. Good afternoon, everyone. Thank you, Kim, by the way, for the introduction. I'm not an expert in palliative healthcare or palliative healthcare needs, but I can consider myself as some kind of an expert in healthcare transition in general, especially for patients with rare diseases. And I want to provide you some insights on the transfer or the transition of adolescents and young adults with palliative healthcare needs or any other complex needs from the pediatric department to the adult healthcare services. In general, when we develop as a human being and become or start from a dependent child to become an independent adult, there are a lot of developmental changes with phases with multiple changes. And if you have in addition a serious chronic illness that results in an additional challenge to really make sure that we develop appropriately or to until our full capacity. And this often results in various issues like self-esteem, like the inability to take up responsibilities, feelings of social isolation, fear of rejection, discrimination, and so on. However, this developmental phase is also a window of opportunity because patients' needs of the needs of young people, they change all the time. So we have to perform comprehensive assessments, and thereby we can also establish a patient-centered plan of care with positive healthcare behavior. And it's a window of opportunity to really continuously assess and adapt this patient-centered plan. There's big difference in the terminology between transfer and transition. Both are needed when patients will be transferred to the adult department. But just to give you some clarity, the transfer is really about the movement of the adolescents and young adults. And it has one major implication, which is we have to ensure continuity of care, whereas transition is more a psychosocial component of growing up, of developing. And it's mainly the planned process that addresses the medical, psychosocial, educational, and vocational needs of young people as they grow up and learning to live with their chronic health condition. The transfer, as I said before, it's mainly about continuity of care or ensuring continuity of care, and continuity of care has three main domains. Being the first one, relational continuity, which implies that a patient should always have a regular source of care where they can go to, but also informational continuity, which implies that there should be an adequate transfer of information, not only between healthcare providers, but also between the patients and the healthcare providers. And there should also be some kind of management continuity, implying that there should be a consistent approach in how we manage their health condition. Important to note is that if you have our patient presents him or herself with a complex disease, then management continuity is or can only be achieved through effective collaboration between departments and healthcare services. The practical implications are that regarding or referring to relational continuity, patients should always know who to contact and where they can receive care or go with their questions if they have unmet needs. Related to informational continuity, there should be always a very complete, clear, and transparent medical file for patients, and there should always be a brief or debriefing between healthcare providers from the pediatric department and the adult departments. And as I said before, based on management continuity, there should be an effective collaboration and coordination of healthcare across boundaries of current services. Related to transition, so more the psychosocial component of transferring to the adult department, there are a lot of components that could be integrated into a transition program, ranging from educational programs to tailored or patient-tailored plans, administrative support, counseling, training, skill training, and so on. But in general, if you look at the literature, a standardized transition program mainly consists of various phases, with the first one being an introduction phase where patients and their parents as well are informed about the next steps when they will be eventually transferred to the adult department. Then starting from the introduction phase, we will facilitate or promote skill development in patients as well as, or in young people, as well as in the adults or in the parents. We will also continuously assess the transition readiness, which is like a measure to assess self-management, and then to eventually go to the planning and the transfer phase, in which we will completely transfer the patient, including the responsibilities of caring for a young person from the pediatric department to the adult department. I've been searching in the literature also for some programs related to pediatric palliative care, and I came across the Stepping Up program from the Together for Short Lives initiative from the UK, and they have established 5 standards which are quite similar to the standardized transition program in general, with the first one, or the first standard or phase, being to prepare adolescents as well as their parents for the change. And this implies that we have to offer choices and inform young people, so they will be eventually able to make well-informed decisions. The second phase is to involve them, to assess their psychosocial needs, and to really discuss their perspectives and their experiences or unmet needs with the young person as well as with the parent. In the third phase, we will eventually have to co-develop an advanced care plan and a pain management plan, for example, but also we have to discuss the goals of care and a code status. And phase 3 is really an important aspect or important phase in the transition process, because it is characterized by the continuity of care principle, as I explained earlier in the transfer concept. And then eventually we will go to this fourth phase or fourth standard, which is that pediatric departments and adult departments should really work together to enable a smooth transition. And I have some difficulties with the suggestions or recommendations that I found in the literature, because the literature says that there should be an overlap of pediatric and adult services up to the age of 25. And I have some difficulties with this, because an overlap also means that it's quite unclear who should be responsible to really coordinate the care, to really have the medical end responsibility. And that's why I always recommend in our hospital, as well as in other hospitals, to have quite a hard full transfer, but a very clear and transparent transfer in line with the legal and ethical practices, that there should be one point of contact that young people as well as parents can always contact and can receive an answer, or that person can address the unmet needs. And there should be clear communication strategies with joint consultation as the transfer points. And then the last step is really to provide the coordinated and multidisciplinary care according to the care plan that has been co-developed on the adult care service. I will skip that. So we know in theory how to perform healthcare transition and the transfer, and still we encounter a lot of difficulties to implement such a transition program. And that's why I'm very a fan of the following quote, which is the proof of the pudding is really in the eating. We know in theory what we should do, still in real world or real practice, it's very hard to adequately support our patients. So that's why I also searched the literature on which barriers are there to really efficiently perform or conduct transition in pediatric palliative care. And I found that there are a lot of barriers identified in patients as well as in caregivers and parents, but also in healthcare providers. And the barriers that were identified in healthcare providers, as you see here by the arrows, they are mainly related again to the concept of continuity of care, of relational, informational, and management continuity. In this study, it's a study performed in the USA, in New York. They recruited, in a tertiary hospital, they recruited adolescents and young adults on the adults department who received palliative care in the adult department, but were also eligible to receive palliative care on the pediatric department. And it's very interestingly to see that only 10 of the 44 patients received pediatric palliative care, whereas the exposure to palliative care was only established in 34 of the patients on the adult department. And this is quite interesting because if you look at the graph on the left side, you see that palliative care, which is here the first category, that the gap between the pediatric and the adult visit is actually 0 months. So the last visit on the pediatric care department was immediately followed by a first visit on the adult department, which is some sort of a parameter describing the gap between those departments. And as you can see, those patients that were not followed or were not exposed to pediatric palliative care, but still had palliative care needs, their gap in care was actually quite large, ranging from 1 month on the hematology department to even 40 months on the psychiatry department. They also explored the reasons for referral or the referral reasons towards palliative care. And on the adult palliative care, or referring to the adult palliative care, the referral reasons or sources were partly from inpatient sources as well as from outpatient sources. And it was very interesting to see that on the pediatric department, patients did not have access to palliative care based on outpatient clinic activities. Patients were only had access to pediatric palliative care services when they were admitted to the hospital ward, which is quite a gap in care and also a very big barrier in access to healthcare and to pediatric palliative care services. Then if we take a look at which kind of palliative care that the patients received, we see that those that were exposed on the pediatric department, they already had a conversation regarding the goals of care, but also code status and healthcare proxy before their transfer, because in the USA, the legal age is actually 21, I believe. So they are already informed, or the goals of care are already discussed before they turn legal age, whereas those patients that were not exposed to palliative care on the pediatric department, these conversations only took place after the transfer. And this is very interesting because this means that if we utilize pediatric palliative care services, that also facilitates continuity of care, because that discussion about the goals of care and the care plan is really the main theme and concept of providing transfer and making sure that there's continuity of care. So in conclusion, there are still a lot of barriers and challenges that are remaining in the transition of adolescents and young adults when they transition from the pediatric department to the adult care services. Also, we should try to introduce palliative care very early to young people or young persons because it facilitates a smoother transfer of care. Adolescents really have limited access to pediatric palliative care services, and mainly only in outpatients or not in outpatient clinic activities. And we should aim to really assess palliative care needs already in the outpatient healthcare activities on the pediatric department. My take-home messages for you are that pediatric palliative care is really a facilitator for transition. So if we could start already the palliative care supports before the transfer, then I really recommend you to do that because it facilitates the transition and makes sure there's continuity in healthcare. Also, make sure that the basic principles of continuity of care are always ensured, meaning that patients always know who to contact at any stage of their transition process and where they can go with their unmet needs, that all the medical files are transparent and that there's been a briefing with the adult healthcare providers, and that the goals of care and a care plan is already co-developed before the transfer with as well the parents and the young people. And then my last take-home message is, especially to the healthcare providers in this webinar, and mainly related to the access to healthcare services, because we should really aim to already introduce palliative care before the transfer. So make sure that if you have a consultation in an outpatient clinic, for example, that you assess their palliative care needs, and if it's appropriate, already start the palliative care support, because it can really support young people as well as their parents. Thank you.
Thank you, Karsten. We take the questions at the end, right? Maggie, so you introduced
Yeah, I have two questions to Karsten. Yeah, Karsten, sorry. One is, you talked about an early start with information, and the start was at in between 9 and 14 and 12 years. Fits this with expectations from parents and children? Because in the practice, sometimes parents say, "Oh, it's way too early. It's way too early because he or she, my child is 9 or 11 or 10. It's too early. Please, is it fitting? It's early in between 9 and 12.
Yeah, I think for some people it would be a fit, for others not. I think if patients and parents are open for future perspectives, if they have like future perspectives, then of course that conversation should already take place, because then you should be planning the transfer. Of course, if a 13 or a 14-year-old is just living in the moment, as well as their parents living day by day, you shouldn't be talking about transferring the patient when they are 18 or 21 years old. Then I would recommend you to maybe provide some hints here and there, but not to how to say it in English, to really pressure the parents or pressure the young people.
Give it a try. Yeah,
exactly.
Give it a try, and if the parents are not in the situation, or it's not a good moment, right, quit it and try later.
Yeah, that being said, the legal age or patients turn when they're at legal age, when they are 18 years old, for example, then I believe it's good to pressure that information onto the young people and the parents, because there's a lot of difficulties when patients are still treated on the pediatric department and they are actually legally an adult. And I would recommend you to steer away from the recommendations that are currently found in the literature that the transfer age should be extended to 25 years old, because I think it introduces a lot of risk for healthcare gaps.
Yeah, but then on the other hand, you talked about the sources, and sources are a big problem. We know there are a lot of sources and available for children's palliative care in countries as Belgium, Netherlands, Germany, and so on, and UK, and so on. And there are a lot of sources for adults, but there is less in between. Sources really for young adults, in homes for young adults, with the environment made for young adults. How can we fix this? Because we can make a nice transition plan, but if the caregiver on the other side isn't there, what to do? And that's maybe also the problem why children's professionals keep going on with the care longer than 18.
Yeah, I can understand that perspective from a professional or a healthcare professional perspective. Of course, we should aim to develop some adolescent and young adult proof program that really suits their age-appropriate needs and so on. But the thing that we can do already now is to be very clear and transparent to parents as well as young people. If they cannot, or when there is no age-appropriate strategy or material in the adult department, just say to the parents that it is this way, and you have to prepare them for reality and not keep them on the pediatric department as long as possible. No, the reality is as it is, and you should just be very transparent to patients as well as to their parents.
Thank you very much, because Karsten, this is a fantastic bridge to our new speaker. She can talk hours about this problem. It's a really, really great pleasure to announce our next speaker, Mathilde Bond. Mathilde is from the Netherlands. She is a mother of Metania, and it's a lovely 18-year-old young man. Not young boy, it's a young man. And Mathilde will share her experiences with the difficult phase of transition. So Mathilde, the floor is yours.
Thank you very much. Hello, everyone. First, thank you for this opportunity to share our experiences. And first, my story is on the slides. I think I don't mention all what I have written because of the time. Next slide, please.
And Mathilde, we are good in the time, so you have a little, I think, quite some minutes more than expected.
Okay, thank you.
Take your time.
Okay. On this picture, you see my son, Matanya. He's a really fantastic boy. I'm calling him a boy because an adult is still, for me, a bit awkward. Because of his developmental age, that's about 6 months. This summer, Matanya became 18. So we're in the middle of this transition process. Matanya is dependent in many ways. He cannot speak with words, but he can speak without words. And he shows his affections. He laughs a lot, and he can also make clear when he is not happy. Next slide, please. Matanya is born at home. We expected a healthy child, so the delivery was at home, and you see in the picture what a beautiful boy he was. But after 1.5 days, he appeared to be in a coma. So very early after his birth, due to a high ammonia value, it was toxic, really, really high level. In the Radboud UMC in Nijmegen, he is diagnosed with a metabolic disease, an OTC deficiency. One of the urea cycle defects. He had a life-saving dialysis, and that made that he woke again, and he's with us. But he endured also a severe brain injury due to that coma. And yes, that was life-changing, because we expected a healthy child. And suddenly we were parents of a very ill boy with an unknown life expectancy. We had no idea what we could expect. And then at that time, doctors told us that the first 4 years would be crucial. And it turned out to be, because in that 4 years, in that first 4 years, he had many hospital admissions. And yes, when he was 3 years old, he had again a severe coma. He almost died. It was, I think, his strength and his will to live that made him stay with us. And it was beautiful to see. The first time he opened his eyes again, we were so happy. And the next day, he smiled at us, like he wanted to say, yes, here I am. So that's very important for us to know his will to live. But also this coma had more injuries in his brain. Yes, his life is vulnerable, and the daily care is very heavy. He lives at home with us, with our family. But from when he was about a year and a half, we were advised to let him stay in a children's hospice. And that was really important for us to be relieved in the daily care. And he is still going to that children's hospice. And very helpful in that time was that advice from that social worker, because we as parents thought we had to do it on our own, and we could do it because he's our child. But that relief was very needy. And what I mentioned was that having the same pediatric doctor from the start until he's 18 was very helpful. In Nijmegen, the Radboud UMC, in that hospital, is a very steady team. So that was very nice for us as parents. Next slide, please. Becoming 18. We never expected him to be 18 when he was younger. We had no idea. So in the first place, we were very grateful. And secondly, also as a realization, his youth has come to an end, but it never really started because of his developmental age of about 6 months. So it's also that grief, and also the contrast with other 18-year-olds, and that, yeah, the gap is really enormous. So that's also painful, and still we are in this uncertain situation about his future. So yeah, instead of letting go like normal 18-year-olds, it's still holding on, and yeah, for the future, for God knows how long. And that's also one of the things I want to tell you about how heavy it is to be a parent of such an ill child. Next slide, please. And then we're in this transition because the Radboud UMC has a policy to make this transition happen. It's initiated by the pediatric doctor. At the age of 16 and a half, the process started with an explanation. And that for us, it was like, oh, he's going to be 18, and how should that be? And we were worried about that time. I was as a mother. And in this process, we were helped by the policy, what the doctors had. The involvement of the adult doctor, the internist, metabolic disease. The acquaintance was like around the age of 17. She was involved more like on the background. But for me as a mother, it was good to know that they were all already busy with this transition. But there's also a thing in the Netherlands, the pediatric doctor is like a generalist who has overview of all different areas of the care. And in adult care, there are more like specialists, and for me, that's a bit tricky. Who is keeping this overview? And in this transition process, the pediatric doctor has all these different areas, all these different specialities that is transferred to another doctor, to another paramedic. So that is very, for me, it was clear to who I have to go for a specific care, ask a question. And in a team meeting, all the involved doctors and paramedic were invited to make this appointments. We also had support from Children's Comfort Team. It's a specific palliative care in Radboud. And for us, it was very good to know that this type of care, these people are still available also in adulthood, because there's not such a team for adults. This Children Comfort Team, isn't yet developed for adults, so we can still make our way to that team. Our last visit to the pediatric hospital was about 2 weeks ago. So we're very in the middle of this transition. And for me, when I was 2 weeks ago in the Radboud, I realized how many people we know. I walked through the corridor and it was hi. And oh, hi. That's for me as a parent was so important, and that they knew Matanya by name. So I want to share that with you. Next slide, please. I just mentioned the transition in the hospital, but next to that, there's also around 18 this transition at all areas of his life. In his daily life, there are many changes around 18 years. It's at the daycare, it stopped. And so we had to look for a new place for daytime activities. The paramedic support stopped within the daycare. So we had to organize that for a new situation. Also the financial and legally changes. So in all these areas, we had to make decisions. So it's not just the transition in the hospital, in that care, but in all of his life. So yeah, that's heavy. It helped us a lot that we had an independent client supporter, someone who is for us as a parent, for support, and they helped to share information, and very helpful for us. And next to that, the support of family, friends, and other parents in the same situation. But I experienced, besides all that support, that it is also a very lonely process, because we had to make this decision for our child, and there are not so many parents in the same situation. It is a real, abnormal situation. So that I experienced that as a lonely process. And next slide, please. Yes, after this transition, or actually in the middle of this transition, I can tell you the things where I'm content about. The 18 years in the pediatric care were like a warm bath, because of very yeah, kind people. Yeah, the presence in all the medical information is just a bit of kindness, so important. So yeah, really important. Also, the people know about your home situation, and they also ask about Jonathan and Levi, about the brothers of Patania. This kind of yeah presence, it's very important for us. Also, I'm really content about the children's comfort team, in that they are still available, and that specific doctor listened to our fears of losing Matanya, because yeah, we live with a constant fear actually. And the doctor gave me the information that Matanya himself will tell us when he is ready to leave his life. And for me, that was very important, because for me as a parent, it's I cannot decide about his life, and I don't want to do that. It's too big for me. And for me, kind of reassurance that one day we can let him go. Also, we don't want to do that. Next slide, please. And the points of improvement. We have had our last visit with the adult doctor in the pediatric hospital, but we haven't been in the adult hospital yet. So that's for us all new, and it won't be helpful. It would have been helpful for me to take a look at that new place, and before there is an emergency, or before there's an admission. So that's one of the things that could be better. And there are some points of worry, and that's about do these adult doctors know what Matanya needs, or do we have to speak out louder as parents? And that's quite a responsibility, because we speak for him all these 18 years, but it's also heavy, because we as a parent also don't know what's best for him. Yeah, we try, but that's also difficult. And who will take responsibility when his needs become more complex? And I talked earlier about the generalist function of the pediatric doctor, and in the adult care it's like more scattered. So that's one of my points of worry. And yeah, there's less expertise, because this type of ill kids didn't reach adulthood in the past. So there's so much unknown, and yeah, for all of us it's unknown. So for me that's quite frightening or uncertain. I think that's the best word. So this is what I wanted to tell you about our experience, and maybe summarizing, this 18 years had a lot of impact at all areas of our life, and in this transition it's that like, oh, it's like we have to start all over again, but we also have this 18 years of care. Yeah, we have already done that. And sometimes I'm quite tired of that, and it's never stopped. So, and maybe then it's for doctors in the adult care helpful to know every the kid has already a story of 18 years. So ask about it and make that relational connection. Thank you, Karsten, for that word. So thank you very much for your attention.
Yeah, I think I'm not the only one in this audience who's quiet a bit, because it was a very impactful speech. Thank you so much, Mathilde, for sharing your story with us, Matania's story with us. I could feel your loneliness, all the difficulties you are reaching, but I also feel the hope, and that's nice. It's so nice to feel. And I know Natania, and he's such a nice boy. Yeah. So thank you very much. There are no questions from the audience yet, guys, think. But maybe everyone is a bit quiet from the story.
I have a question, if I may.
Yeah.
And it's for all of the three speakers, actually, because especially the first two are very related to the hospital, maybe also because of your function there. But I heard also Mathilde saying, like, we have a pediatrician, and in the Netherlands, they play a role as a general practitioner. And I think the role of the general practitioner might be or could be very important, or at least you should have somebody who takes that role, but also the role of the community. That's two separate questions. So maybe for the GP, both Alex and Karsten, and maybe then also Mathilde, what do you think the role of the GP can be, could be, and what is necessary in your countries to improve that?
Okay, maybe I'll answer first. And Mathilde, thank you so much for sharing your lovely boy with us. It's very moving to see the whole story over the years. I think a GP is absolutely integral. However, we also know that they, at the early stage, if we're talking about a baby that's on a neonatal unit, is the capacity of the GP is very stretched. So we have health visitors, which are nurses that oversee babies for the first 5 years of their life. So very much focused on weighing, making sure they're growing and developing out in the community. So we make links with the health visitors, and that's the only first 5 years of life. We make links with the health visitors in the first instance, so they have more capacity and ability to connect and meet with the family first. So you have that link with the community as a first space. Many of the babies from a neonatal unit, when they are discharged home with complex needs and that uncertain future, may also need support from the children's community nursing teams. So it's very important that the acute people in the hospitals connect and make the referrals as early as possible with the community, because we don't know when these babies are going to go home. So they will need to have that in place already. But again, within the UK system, we're very, very fortunate to have access to 54 children's hospices. So sometimes the children's hospice services, it's different in every single hospice. They all provide a different service, but primarily it's similar. So that's part of the work that I'm doing nationally, is bringing the hospices together with the acute people in the hospitals, because many children's hospices will support the care that these babies and families need. And they're already in the community. So they will continue to support the whole family in the community. So we are fortunate we have various ways, but that's why it's really important that you have one person who is the key worker to coordinate all of this. And you don't want to keep changing doctors and nurses and different people. You want to have consistency. And we know that from many families, again, like Mathilde said, is they have so many healthcare professionals involved in the care of their babies and their children that it can be very difficult to coordinate that. So there needs to be a healthcare professional to coordinate that, but also to minimize, to try and support these families to live a life, and not just all be about hospital appointments and hospital care. So I haven't got a straight answer for you, Kim, but it's very, we have these resources, and we're very lucky, but also we know it can be very difficult to get people involved at the beginning. We've been doing a lot of work as well with community pediatricians, who traditionally they might be contacted at the time that the baby is discharged home, or might be once the baby has been home for a while. But more and more community pediatricians are saying, tell us about these babies and families whilst they're still on the neonatal intensive care unit, so we can be prepared and build a relationship with those families. Because we also know that when many of the babies are discharged home, when they come back into the hospital for any reason, they go to children's services. They go to either PICU or paediatric care. So again, it's having that consistency and support throughout.
I can maybe add to that as well, if that's allowed. Yeah. Okay. Well, in Belgium, and especially if you have a complex disease or health condition, the pediatric or pediatrician at the hospital often becomes really, well, there starts to develop a friendship-like relationship between parents and pediatricians. And this often also results in, if a young person just has a cold, they do not go to the general practitioner, but they go straight to the specialist at the pediatric department. And it's very difficult to create a similar relationship, I think, that already exists between the pediatrician and the parent and the young people, to create the same relationship between a general practitioner and the parent, because they have the feeling that they are so confident in the hospital system, and that it's very strange for a parent, in my perspective, to completely shift the focus outside of the hospital context towards a general practitioner. And I think that it would be best to search for a similar kind of profile also within the hospital on the adult department, or discuss this with your general practitioner, whether he seems it possible that he could take up such a role. But I would not assume that every general practitioner can take up a coordinating role to meet all the unmet needs of patients, both on psychosocial unmet needs as well as medical unmet needs and so on.
Yeah, I agree to you, Karsten. And also, it's what I meant was the generalist role of the pediatrician, and in contrast with the more specialists in the adult care. And I really, in this adult care, my worry is about who will keep that overview. So, and then it may be in this part, and when it's about palliative care at home, maybe then general practitioner can be supportive. But in our lives, the general practitioner isn't so much involved, actually. But it's all mainly about the generalist and overview role.
But Mathilde, you could, for example, ask the question just to a specialist at the adult department. That's, for example, I have a question about life insurance. I don't know what. Who can I contact? And then it's a specialist's responsibility to make sure that you have contact details to access the information that you want. And I think that's the most important part, that you feel supported on those aspects where you need support, and it's perfectly okay for you to just ask the question to a specialist. And then, of course, you can be referred, whereas a pediatrician would probably solve everything themselves. You cannot expect it from an adult physician. But I think if you ask the question, it should be his or her responsibility to refer you to a person that really knows the answer and can help you.
Thank you.
I think overall, Mathilde, it's a question, and it's for all the speakers. It's a question from coordination with a bit of case management, but also political questions to bring all the services together for the continuum Alex was talking about. I think that's I feel the big need in your case for the coordination, someone who holds all the red lines, put it all together.
And knows your story. I think also that element.
Yes.
That was there from the beginning. Of course, some people change jobs and stuff like that, but like somebody that follows you.
We had two questions in the Q&A, and in the I think the time almost. Jitka, I have a look at Jitka.
Yeah,
Jitka.
I have 2 messages from Mathilde from the chat. There are no questions, but you can see them, I think, as well. But let me read them. We can express how grateful we are to have you sharing this secret journey with us, Netherlands. Thank you so much. Love and blessing from Borneo. And the second message is thank you for sharing your story, beautifully told and very powerful, thought-provoking for me. So I think that would mean for many of us that we have a question how to make your life easier, but also, as Karsten said, there are difficulties on our side as well, because we usually letting the children and you as the parents go, and it's the relationship which actually makes the things nice, but also many restraints and a painful or sad situation that we have to let the children and the family go. So we spent maybe 18 years together, somewhere even longer.
There is one question for Mathilde in the Q&A, and Mathilde, if you don't want to answer them, it's okay, because it's what was a question about the heart of your journey with your son over the past 18 years, and how that had impacted both of your sons and your family as a whole.
Sorry, I
Difficult.
It's the beginning of the question.
What was the heart of your journey, the core of your journey with your son over the last 18 years of the past 18 years?
Oh, the heart.
Yeah,
Oh,
it was the heart.
Oh, that's I think Matanja's smile when he woke up from his coma when he was 3 years old. His will to be alive and to show his love to us. And he cannot, I told he cannot speak with words, but without words, he tells how much he loves us. And that's also our love for him. But I think that is really the reason why I'm still smiling now. So, yes.
Yeah, and the second question was what's the impact for both your 2 sons and your family in the whole? What's the impact?
Yeah, the impact is huge, because it changed also my future perspective. I myself was being a doctor. I was in the training, and I stopped with that. To take care. That's one part. It affects all areas of our life, and it's both heavy and very meaningful. So it made me also like what's really important in life, and that for me it's quite obvious. That's not a good word, but for me it gives me the meaning of life, to take care for him. And
wow, that's very nice. I think that meaning is the I think meaning is the term for everybody here in the audience, speakers, everybody who works in children's palliative care. It's meaning, it's meaningful, it's meaning giving. And it's on one side, it's hard. We all have very hard moments. And on the other side, it's so meaningful. So that's a nice, nice comment, Matilda. Yeah.
Thank you. I'm following the time, and it's 3 minutes till the end of our webinar. So unfortunately, I'm afraid we won't have any more time for questions and answers. But I think we can wrap up, Maggie, the webinar. As I said, it's in my head, it's many questions and maybe invitations. And what I think it's in my head, thanks to Alex and Karsten and Matilda, more thinking of transition as a continuity, because somehow it's less scary than transition, and that there will be something. And what the highlight for me is that what we know, and it's more reminder that we have to know each other. That means like not within the adult services only, but maybe in the regionally what's in the children and adult services, and the continuity and the transition and the handover, even for us, even for parents, might be easier, because the information is one of the key elements.
That's a nice roundabout. And share our reference group, join us, because networking and building networks for these parents and children as Matilda is what we are doing. So join us